During the next few minutes, we are going to discuss the management options for a child with iron deficiency anemia, as well as to understand causes, clinical approach, and management of child with vitamin B12 or folate deficiency. For the management of a child with iron deficiency anemia, first, prevention. Prevention is based on nutritional therapy. It's important to maintain breastfeeding for at least 6 months when possible, to introduce iron-containing foods in the full term from the 6th month onwards and in the preterm after 2 months, to use soy-based formula or amino acid-based formula when iron deficiency is due to cow milk hypersensitivity. What about the therapy? Oral iron therapy is our first choice. The dose is 3 to 6 milligrams per kg per day of elemental iron based on empty stomach, not taken with milk products, and given as 3 times a day. Duration for 6 to 8 weeks after hemoglobin returns back to normal to replenish the storage. Vitamin C will enhance iron absorption, and if there are GIT side effects, use every other day. We expect the response to increase the reticulocytic count on day 5 to day 10 of the therapy onset and a very slow rise of the hemoglobin. Don't be in a hurry. But if the patient doesn't respond to oral iron therapy, look to if he is having a persistent or unrecognized blood loss, if there is defective administration, defective dose or preparation, or there is a coexistent disease that interferes with iron absorption or utilization, like the presence of infection, malignancy, hepatic or renal disease, concomitant deficiencies of B12 or folate, or concomitant deficiency of thyroid hormone, because thyroid hormone is important for erythropoiesis, or there is lead poisoning because lead poisoning interferes with the iron utilization. If you have a failure of oral iron therapy, are we allowed to think of parenteral iron therapy? It's rarely indicated in children, only in non-compliant severe anemia, in the presence of severe bowel disease, and or in the presence of chronic hemorrhage and there is difficulty of oral uptake. It can be given intramuscular, it can be given intravenous. We do not like intramuscular too much because it can cause aseptic inflammation at the site of injection. Intravenous iron therapy is available. Packed red cell transfusion in iron deficiency anemia is not indicated except in severe anemia with hemoglobin less than 6 grams per deciliter and the child is risky, having an impending heart failure, having sepsis, having preoperative condition. However, only low hemoglobin is not an indication of packed red cell transfusion. The second type of anemia we are going to speak about as deficiency anemia is the megaloblastic anemias. Megaloblastic anemia is a macrocytic anemia, means the mean corpuscular volume is increased. It results from inhibition of the DNA synthesis during the red cell production, as we have explained in erythropoiesis. And it is characterized by the presence of macrocytes in the peripheral blood and megaloblasts in the bone marrow. And the megaloblast is an unusually large dysfunctional nucleated red cell precursor. Megaloblastic anemias can result from folate and B12 deficiency, more than 95% of the causes, and nutritional factors are contributing factors, but it may result also from congenital disorders of DNA synthesis, acquired defects of the DNA synthesis as in liver disease, in sideroblastic anemia, in leukemia, in aplastic anemia, and can be induced by certain drugs like antifolates and antimetabolites that interfere with DNA synthesis. Folate deficiency is relatively uncommon, as you see, because folate is present in many green leafy vegetables. However, boiling foods causes loss of 40% of the folate, and also our daily requirements of folic acid are very small, are very minimum. However, folate deficiency can occur if the child is on pure goat milk diet, because it is found that goat milk is poor in folic acid. Other conditions are a child having chronic diarrhea, malabsorption, jejunal resection, on prolonged broad-spectrum antibiotics causing growth of intestinal flora interfering with absorption of folic acid, on long-term dilantine therapy. Children with chronic hemolytic anemia, they have increased requirements of folic acid and they should be supplied with folic acid. If the child is having malnutrition or if receiving drugs that interfere with folate utilization like methotrexate, pyrimethamine, trimethoprim, and in rare inborn errors of folate metabolism. Vitamin B12 deficiency can result from inadequate intake or defective absorption. B12 is present in mainly animal source foods and less in leafy green vegetables. Deficiency is associated with intake less than 2 mg per day in conditions of malnutrition, and as we explained before, if the mother is severely deficient in vitamin B12 and the baby is exclusively breastfed, the baby may develop vitamin B12 deficiency. Defective absorption is important, and it includes a factor secreted by the stomach called intrinsic factor. Intrinsic factor is important to help the absorption of vitamin B12 in the ileum. So failure to secrete the intrinsic factor associated with congenital gastric disorders or autoimmune gastritis or acquired gastritis like cirrhosis is going to result in vitamin B12 deficiency, as well as specific B12 malabsorption disorders in the ileum. Also generalized malabsorption and small bowel bacterial overgrowth will result in competition for vitamin B12 absorption. And there is a parasite called Diphyllobothrium latum. It's related to a raw fish intake, mainly in Southeast Asia. It consumes vitamin B12 and decreases vitamin B12 absorption in the ileum. The clinical manifestations of megaloblastic anemias include serious onset of pallor, lethargy, anorexia, sore red tongue, glossitis with or without diarrhea. There is suggestive history. And in vitamin B12 deficiency, there are neurological manifestations. In infants expressed as neurodevelopmental delay, hypotonia, athetoid movements, while in older children, as in adults, there is subacute dorsolumbar degeneration of the spinal cord. How we are going to diagnose? Diagnosis is based on the blood picture. We are going to make a blood picture. We found that the hemoglobin is decreased, the mean corpuscular volume is increased because they are macrocytes. There is anisocytosis, red cell distribution width is increased, and there is poikilocytosis. Concerning the leukocytes, let's check. In the iron deficiency, we did not speak about the leukocytes because they are usually normal. However, in megaloblastic anemia, we may get a leukopenia, decrease in total leukocytic count. This is important, and decrease in what we call hypersegmented neutrophils. What's that? Usually in the neutrophil, the nucleus is formed of 3 to 5 segments. But if it is more than 5 segments, we speak of hypersegmented neutrophils, and this is very characteristic of megaloblastic anemia. Also in megaloblastic anemias, there may be decrease in the number of platelets. Bone marrow is indicated. If we remember, we did not speak of bone marrow in patients with iron deficiency, but in megaloblastic anemia it's important because it is going to show the presence of megaloblast. You may go to assessment of the serum B12 level, serum folate level, and red cell folate level. What's the therapy? Oral folate, 5 to 15 milligrams per day for at least 2 weeks up to several months in folate deficiency. Treatment of the cause is important. Chronic hemolytic anemia should be supplied with folate. However, vitamin B12 deficiency should be ruled out. If you supply a child having B12 deficiency with folate, his anemia is going to improve, but there will be deterioration of the neurological disease. And vitamin B12 deficiency to be treated, it needs to be given parenteral vitamin B12 because most of the causes of vitamin B12 deficiency are related to decreased intestinal absorption. So treatment is given intramuscular. Usually it's given monthly. So we are expecting for your questions in the next face-to-face session. Thank you.